welcome back to everyone who's participated in our previous webinars, and welcome to those who are first joining us tonight. Tonight, we are privileged to have Dr. Adam Gavine join us again to show his success using shockwave therapy to treat musculoskeletal disorders. And please feel free, we really welcome any questions throughout the webinar. So post your questions into the chat section. There's a little chat box below, you'll see, press on that, type your question in, and Adam will address them at the end. So Adam, the floor is yours.
Great. Thank you, Danny, for that wonderful introduction. Thanks, everyone, for joining tonight. Hopefully we won't, again, put you to sleep. We'll keep you awake with some of this exciting information. So let's get straight into it so we can all finish up. So we're going to go over the implementation of shockwave therapy in practice. We're going to cover some of the indications and contraindications. So just again, a little bit about me. I'm a chiropractor. I have special interest in sports rehabilitation. I have 2 degrees, a Bachelor of Human Kinetics and a Master's of Chiropractic from Macquarie. I've done advanced training in a soft tissue technique called ART. I'm a certified member of the Specialist Educator for Swiss Dollar Class Academy since 2016. I presented shockwave therapy seminars for EMS in Australia and throughout Southeast Asia since 2016. I've also worked directly with one of Australia's top orthopedic surgeons, Dr. Munjid Al-Madiris. He does the osseointegration, which is basically the bionic legs for amputees. And I worked with him directly when I worked at the Norwest Hospital in Bella Vista. So if you guys have any questions about that, I actually treated some of his patients that had the osseointegration. So that was pretty interesting with shockwave. I'm also a published author. I co-authored the book you see on the slide called Back Pain. I also have 2 clinics, one in Mona Vale and one in Pymble in Sydney. And my ethos is to treat the cause, not the symptom. And that's my website if you guys want to find out more about me. I also have loads of blogs and information about various conditions and treatments that I do. All right, so let's go over a few things. We're gonna do a little recap about shockwave, what they are and what shockwave therapy is. We're gonna look at the different types of shockwave therapy. We'll talk about how it works. We'll talk about the therapeutic effects of shockwave therapy. We'll talk about indications, contraindications. We'll go over some evidence. I know some of you, if you did my last Facebook Live or webinar, you may have seen some of this, so we'll try and go through it fairly quickly. We'll also introduce GDT, and we're gonna introduce the high power laser that EMS has released in the past year. And we'll talk about indications, contraindications for it. And then we'll look at the role of all these devices in GDT in the clinical setting. All right. So there's different types of therapeutic shockwaves. So basically, if you look at the top here, we have just standard therapeutic shockwaves. They're further broken down into subcategories of intracorporal shockwaves which is lithotripsy, and we have extracorporeal shockwave therapy, which is further broken down into subgroups of focused and the radial treatment, which basically the focus is the first kind of generation of shockwave therapy, and with that it was the device is more concave, so the waves that are created come into a focus point, whereas the radial it's convex in shape. So the shock waves that are created go out in a radial or expanding fashion. So just a little recap on extracorporeal shockwave therapy. Here's our new device that EMS has released with radio shockwave therapy. So shockwave therapy has been used to treat an ever-growing list of musculoskeletal disorders over the past 30 years. Shockwave is a single, again, the definition is a single acoustic pressure pulse, which is characterized by a rapid rise and then a rapid drop in ambient pressure, which creates the cavitations. And the energy promotes repair, regenerative processes of bone, tendon, muscles, and other soft tissues. Again, how it works, if we look at the picture here, we have compressed air coming into the handle. The handle has a barrel here that has a projectile. The projectile is pushed by that compressed air. It hits the applicator here, which then creates shock waves with the two phases, which we talked about, the compression phase, which is the positive pressure, and then that's subsequently followed by the tensile phase, which is the negative pressure. So there's basically peaks and troughs here, and that causes the formation of these cavitation bubbles, which is what we believe is causes the therapeutic effects on tissues. And yeah, just a little info there. The air that's pushing the projectile pushes the projectile about 90 kilometers per hour. So the energy is transmitted along the applicator, and you can see it move. We'll go through some videos where you can actually see the movement of the applicator. You actually need some contact gel though too, so that you don't lose any of the energy. It's kind of like ultrasound. If you don't have, if it's just exposed to air, you lose all the energy. So we have to have some contact gel between the tissue you're treating and the applicator. Yeah, which is what I put there. Okay, so here we go again. The fundamentals are, you have the positive compression phase here, followed by the negative tensile phase here, and that gives you your total energy, okay? And with here, it's showing that we get a penetration depth of up to 40 millimeters. Depends on the applicator tip. This is the 15 millimeter tip that we use, and that gives you up to 40 millimeters of tissue penetration. Obviously, it's slightly different depending on the tissue, but that's usually like skin, muscle, tendons, and such. How am I going for speed there, Danny? Good?
Perfect, Adam, perfect.
Okay, all right. So here's a little video. That's the applicator here, and these are it generating some shock waves. This is a short video. You can't see it as well. We have another video with the focus that's a bit longer that you can see it. So I'll show both. So you can see the little cavitation bubbles. They're all the little black specks here that are forming, okay? I'll just play that again. So you can see the compression phase here, and these little circles basically that you can see here, they're the tensile phase, the negative pressure creating those cavitation bubbles. So this is the focus device. As we said before, you'll see the cavitation bubbles form much further away from the applicator. Now, usually you can't see it here, but it has like a big gel bit here that you screw into the tip. So part of the space here is actually occupied by that gel tip. But you'll see the cavitation bubbles that form up here. So you can see that they come in a more focused area. So it's dependent on the depth that you want. You put a different thickness of gel tip on here to get different depths. All right. Here's a video of me treating someone's Achilles tendon, and this is a treatment therapy method that we call ironing. It's just moving up and down along the tissue whilst administering the shock waves. Cool. All right, so let's go through some of the therapeutic effects of shockwave therapy. So there's quite a few of them. So when I tell people about these effects, when people ask the question, oh, can you use shockwave on this? Can you use shockwave on that? I always tell people, think back to this list, because it basically tells you what you're going to get from the therapy. So let's go through it here. You get tissue repair, you get tissue regeneration, you get blockade of neurogenic inflammation, you get decreased cartilage degradation, you get decrease in the amount of substance P, which is that's a chemical released by nociceptors that creates pain. So when we use shockwave and we decrease the amount of substance P, we're basically draining these nociceptors of this substance P, which then causes a local analgesic effect. You also get muscle relaxation. You get improved movement of the tendon due to a increase in lubricin. You get stimulation of tendon remodeling. You get stimulation of proliferation and differentiation of osteoblasts. So that's where it helps for a lot of bone conditions like non-union fractures in like the head of the femur, which can be a problem for a lot of patients that suffer that condition. You get stimulation and proliferation of tenocytes. Obviously, that helps with tendon problems. You get collagen synthesis. You get neovascularization, which is a new formation of blood vessels. You also get release of angiogenic growth and proliferating factors. So you get angiogenesis and increased local blood flow. All right. So again, going back to that list, I can't think of too many tissues in the human body that wouldn't benefit from some or many of these therapeutic effects. So again, if you want to answer those questions of will it help with this? Well, if that tissue can benefit from any of these physiological benefits, then you have your answer. So of note is that the effects of treatment continue to influence physiological changes long after the treatment has ceased. So again, it's like the picture shows, it's kind of like fertilizer. When you give fertilizer to the plant, it doesn't just work on the day that you give it, it works the day after, the week after, the month after. And we have studies that show that even one treatment with shockwave therapy with our device has been shown to have therapeutic effects up to 3 months later. So that's pretty powerful. And that's important to tell patients that even after the treatment, they're going to continue to benefit from that treatment, which is pretty cool. So we talk about the dose-dependent treatment here. So it's really important to get to, most of the studies show that it's the high energy that causes better therapeutic effects, okay? So we talk about the cavitations. More cavitations cause greater therapeutic effects, okay? And the way you get greater cavitation level is the result of high amount of energy density. So that's the amount of energy that's being put into the tissue. So it's about how much pressure in terms of bars that you're administering to the patient. Now, the problem obviously is when you ramp up the bar pressure, it tends to be a little bit more painful. So we're always mindful of working with the patient within their tissue and their pain tolerance levels, okay? So if someone's, screaming out saying it's a 10 out of 10, obviously you need to decrease the pressure. All right. So the higher the total energy, the better the treatment outcome, as per these studies showed. Now, here we talk about changes we've made to the handle, where we now can use higher frequencies, 15 to 20 hertz. We used to get a decrease in the energy density when you went to these higher frequencies, and you can see here with the device, even our device is the blue, when you're at a low energy density. So that's pretty close to 2 bar. 2 bar equals 0.05 millijoules per millimeter squared. So that's just above, that's probably 2.2 bar. And you can see there's very little decrease in the energy with the increased frequencies. However, if you look at our competitor, one of our competitors, as you increase the frequency, particularly down here at 15 hertz or greater, you get a significant decrease in the amount of energy delivered to the tissue. And again, that's very important, because we just elaborated how it's important to give those high amounts of energy to create those cavitation bubbles, which in turn cause the therapeutic benefits to the tissues that we use, that we treat. And you can see that illustrated quite well here in this slide. So again, these black spots on the slide are cavitation bubbles. This is our EMS Doller class at 4 bar, which is a very high, it's the highest pressure that it goes to at 15 hertz. So you can still see that it's generating quite a few cavitation bubbles. Whereas if we compare some of our competitors like Storz and BTL, and particularly Zimmer, you can see there's hardly any cavitation bubbles being formed here. So you can imagine what kind of therapeutic effects you're going to get if you're using this device. So we really want people to understand that you're not comparing apples to apples here. Okay, it's like a car. It's like comparing a Ferrari to a Pinto. Okay, they're both cars, yeah, but one is a finely tuned, handmade performance machine, and one is a car. All right, so you get different effects, and you get what you pay for. Okay. So we try and maintain a high standard of quality, and we want everyone to get the most benefits from our treatment. How are we going, Danny? Am I doing all right? You still there, Danny? I'll just keep going, assume I'm going okay. So we got indications and contraindications. So there's quite a few, and the list is ever expanding, because we get new studies done every year that show further indications that can benefit from the treatment. So obviously we have all the tendinopathies. We have adhesive capsulitis. Trigger points are otherwise known as myofascial pain syndrome. Acute and chronic muscle aches. Acute and chronic lumbar and cervical pain. You obviously have all those conditions. Superficial non-unions, stress fractures, and Osgood-Schlatter's disease. Painful exostosis, including heel spurs and Hageland's deformities. Knee osteoarthritis. Stimulation of acupuncture points in pain management. Proliferative connective tissue disorders such as Dupuytren's, plantar fibromatosis, and Peyronie's disease. Spasticity such as cerebral palsy. and skin diseases such as acute and chronic soft tissue wounds. So it's quite effective for wound healing. Obviously, there's special precautions that need to be taken when doing that. Calcifying tendonitis of the shoulder, subacromial pain syndrome, epicondylitis of the humerus, patellar tip syndrome, or otherwise known as jumper's knee or patella tendinopathy, medial tibial stress syndrome, Achilles tendinopathies, plantar fasciopathy, pseudoarthroses, and chronic painful muscular hardening. So yeah, trigger points. All right. So we're just going to go through a few common indications that I see in my clinic. One being Achilles tendinopathy, one being plantar fasciopathy, and another one is lateral epicondylalgia or tennis elbow. So here's some images of basically they're just finding they've penned in basically the most painful spot on this patient so that they can zero in on it here. And again, they're kind of doing that ironing technique we talked about, working along here. It's the lateral aspect of the Achilles. As we know, Achilles tendinopathy is an overuse syndrome that happens when the tendon's unable to adapt to strain being placed upon it. Leads to repeated microscopic little tears that occur, and that becomes cumulative over a while, and then the tendon becomes degenerated and less resilient than it should be, so it becomes painful. Occurs more commonly in running sports. Many people complain, obviously the pathognomonics with that is people, complain that they're really stiff after they've been sitting for a long time or when they first get up in the morning, but it usually eases after they've been walking for a few minutes. And obviously there's the two main categories of mid-portion Achilles tendinopathy, which accounts for about 55 to 65%. And then you have insertional tendinopathy, which occurs at the insertion. So here again, we are talking about plantar fasciopathy. And this is just a method that we promote of palpating and then identifying, indicating where the area of or areas of pain are, and that way you don't have to keep searching for it once you start treatment. I tried when I first started doing it without that. I found that I kept having to find the spot, and I was wasting a lot of shocks. So it actually saves you time, and it saves the device from unuseful shocks. So you can be very, very specific and targeted with the treatment if you mark the spots. Also with plantar fasciopathy, also called plantar fasciitis, it's another overuse syndrome, results in collagen degeneration of the plantar fascia. Typically, it hurts the most at the medial calcaneal tuberosity, or the insertion of the plantar fascia. A lot of them now term it as plantar heel pain due to the fact that there's several sources of pain in the plantar heel region. It's not always plantar fasciopathy, so they like to use the term plantar heel pain now to encompass, be more all-encompassing, so you can't get it wrong, really. So plantar fasciopathy occurs in about 10% of the general population and accounts for 11 to 15% of all foot symptoms requiring professional care. And the good news is approximately 90% of cases are treated successfully with conservative care. So we always tell patients, before you go down the route of invasive and sometimes even minimally invasive, try a good course of Shockwave and conservative care before you go straight to that other stuff. Because things like cortisone injections, I don't know if any of you have sent patients for that. It's not pleasant. They don't like it. It hurts quite a bit. And also you have the risk of potential rupture, which is about 2.5 to 10% in the research have ruptures after cortisone injection. A little bit more about the plantar fascia. So you have the three bands. You have the medial band, which isn't that affected. It tends to be the central band here that's affected the most, right here down in the medial tubercle. We have Baxter's nerve, which can be irritated here as well. It's a commonly irritated nerve. You don't necessarily have to have plantar fasciopathy to have problems with that nerve. And that's, again, where we use that plantar heel pain diagnosis to cover that. Yeah. So here's a video of me treating a patient for his plantar fasciopathy, and the sound's not very good on it, so I'll just try and talk you through it a little bit here. Right. So I'm going to just skip to the treatment here. So I'm just talking about how I'm using the 36 millimeter applicator because it covers a bigger area and it helps you just get the job done a bit quicker. And the plantar fascia is it's quite superficial, so you don't need that much penetration, so it's easy to use. And so I'm just checking in with the patient, seeing what his pain level is with that level of pressure, and just getting some feedback. So I'm just talking about I'm treating the lateral band of the plantar fascia right now, which tends to be a little bit more painful, I find, on most of my patients with plantar fasciopathy. And so the patient just confirmed that he's actually more tender in the lateral band than he is in the central band with treatment. So that's fairly common. It's just a biomechanical compensation that most people have. They tend to walk on the outside of the foot a little bit more when they have this. So again, I'm using the ironing technique. You'll see me moving the applicator back and forth over the tissue. So I'm actually feeling, while I'm treating, I'm actually feeling the tissue and how well the applicator slides or glides over the tissue. And when the tissue releases due to the treatment, it actually slides a lot easier, and I can actually tell when it releases. And that usually coincides with when the patient says it's starting to feel less painful or some form of change in their pain levels. So I'm just describing how I'm tensioning his toes, putting his toes into extension to put some tension on the plantar fascia. So again, I can feel where the areas of greater tension are. And when the tissue releases, his range of motion through his toes I'll notice a difference straight away. And so usually the patient does as well. So I've just changed the 15 millimeter tip. And here I'm just going to treat his Achilles because he had concomitant Achilles tendinopathy. And you'll find I always tell practitioners, always check, because they usually come together. There's very few patients that I have with plantar fasciopathy that don't have some degree of Achilles tendinopathy as well. So as we know, with anatomy trains, the posterior superficial back line connects all the way through the hamstrings through the calf, the Achilles, and to the plantar fascia. So we want to work. I tend to work back from the plantar fascia and check that whole posterior chain. Yeah. So I'm just going to treat the Achilles here with the 15 mil. It slots in really well. It's almost like a trough right next to it. And the anterior aspect of the Achilles. So again, you can see me using the ironing technique. It works really well for the Achilles because you can feel where any nodules are or any adhesions. And again, when it changes or releases, you'll actually feel the applicator slide or glide through there much more smoothly. All right, let's go on here. We'll talk a little bit about lateral epicondylalgia or tennis elbow. So again, same thing here we're showing with the pictures. Try to identify, palpate, and mark the areas that are most painful so that you know where they are. I tend to start a little distal, especially if the patient's in quite a lot of pain, because you get the analgesic effect. It will help numb that area a little bit so that when you work up to it, it's not quite as painful. So it's just a smart kind of way of approaching the treatment. Again, it's tennis elbow is the most common overuse syndrome of the elbow. Affects about 1 to 3% of the population. Tends to be 35 to 50-year-olds. Involves the extensor muscles of the elbow, predominantly the extensor carpi radialis longus and brevis. The brevis being more prevalent. And with it, obviously, pain is the main symptom. It usually occurs in the lateral posterior aspect of the elbow, and it can be quite debilitating for a lot of people. Again, it's the extensor carpi radialis brevis tends to be involved a bit more, so that can be easily tested with the extension test of the middle finger versus the ring finger. So that'll differentiate the longus versus brevis. Also tends to occur in workers who work, have a lot of unilateral movement in their jobs, like electricians, carpenters, and gardeners and such. All right, so just on to some contraindications, which are obviously important. So we don't treat over air-filled tissues. It can irritate the lungs. That's actually how they first discovered shockwaves, was during World War II. Some of the soldiers were coming back with lung problems due to bombs going off near them, and that was due to the shockwaves generated by those explosions were causing some damage to their lungs. So we don't want to do that, even though our shock waves are orders of magnitude less than a grenade going off, obviously, but we can still irritate the lungs a little bit. So we try to avoid that. Treatment over pre-ruptured tendons. This is predominantly because of the analgesic effect. If we treat someone that has a pre-ruptured tendon, and we give them an analgesic effect and they go off and do a bunch of running or jumping after the treatment, it can lead to a spontaneous rupture, which we want to avoid. So we tend to tell practitioners to avoid that one, just so you don't get sued. Also, treatment of pregnant women. It's not so much that it's been proven to be unsafe. It's simply we don't have enough studies proving its safety, so we can't say that it's 100% safe. Treatment of patients under 18, except for Osgood-Schlatters, it's a very similar thing. We just don't have the studies to prove its safety and efficacy with kids under 18 with pediatrics. So I think that'll change in the future once we get some more studies done. I use this as a relative contraindication as long as I get consent from the parents and I make them aware of all the risks involved, and I get them to sign a consent form. And I've got quite good results using that on a patella tendon on a 12-year-old. It took about 2 visits, which was amazing, and he was 100% better after 2 visits, so that was pretty cool. Treatment of patients with blood clotting disorders. Obviously, we're talking about people with like hemophilia, so we don't want to, because they can have bleeding problems due to the treatment, so we don't want to mess with that. Also, people on oral anticoagulants. Again, this is more of a relative contraindication. When I worked for the orthopedic surgeon, I would get his okay with certain patients to use Shockwave. But that, again, that's on you as a practitioner to decide whether you're happy to take on that risk. But I had the orthopedic surgeon working in the next room, so I would just get his okay, or he would say, just put it on a low setting and just try it first on the first visit. And if they didn't have any problems, then we would try a slightly higher setting on the next visit. Obviously, treatment of tissue with local tumors or bacterial or viral infections, it's a no-go. And also treatment of patients treated with cortisone. So the caveat being within a 6-week period. So after 6 weeks with cortisone, it's been deemed to be okay to use Shockwave. All right, so again, we'll go through some of the clinical evidence. For those of you who saw my previous webinar, this will just be a little recap. So we talk about the safety and efficacy of the treatment. So this study was done by Christoph Schmitz in 2015. It was a systematic review. I think it involved 26 RCTs. So the conclusion was Shockwave therapy is an effective, safe, and non-invasive treatment option for tendon and other pathologies of the musculoskeletal system. It was shown to be 88.5% effective in the RCTs that had, so the R here and R ESWT means radial, and here it means the small f means focused. So 88.5% with the RCTs on radial Shockwave and 81.5% with RCTs on focus found in Pedro had a positive outcomes regarding placebo or alternative treatment modalities. So those are huge numbers. Like if you look at other studies for the efficacy, most studies don't have anything near that for their interventions. So that's pretty cool. Now, the study also showed that focus shockwaves provided no better results than the radial shockwaves. And in fact, if you look at the numbers, radial shockwave had a little bit better, but that doesn't mean that it works any better overall. That's just this systematic review found that. Again, it showed that supplying sufficient energy to cause a treatment effect was you need that certain amount of energy to cause the best effects, therapeutic effects. And the 2 studies demonstrated that application of local anesthetic in the area of treatment adversely affects the outcome. So that's where if someone has like the cortisone, even if it doesn't cause any tissue problems, it's still it negatively affects the benefits of Shockwave, because we want to work, we want to stimulate a little bit of inflammation in the area to cause the physiological effect in there. And if the person can't give you any feedback because they've had some anesthesia, then you can actually have the pressure up too high and actually cause some tissue damage, which we don't want to do. So they also found the optimum treatment protocol for Shockwave to be about one week intervals and about 2,000 impulses. Again, that 2,000 impulses is per area, and turned up to the highest pressure that the patient can tolerate. So this study, again, shows the safety and efficacy of the therapy. It was a study by Liao in 2018. It was, the aim of the study was to look at the efficacy of Shockwave for knee soft tissue disorders compared to efficacy of different Shockwave types, energy levels, and intervention duration. The conclusion, out of 19 RCTs and 1,189 patients, there was no or zero adverse events, side effects, or complications. So that's about as good as you can get. As I've stated before, you can't get better than zero side effects or adverse effects. So out of 1,200 people, that's pretty good. They concluded that the study provided limited to moderate evidence that both focus and radial shockwave with long-term intervention periods are superior to those with short intervention periods, regardless of energy levels. So they're showing you get a better result if you have a longer treatment period. So this study by Gerdes-Meyer looked at radial shockwave therapy is safe and effective in the treatment of chronic recalcitrant plantar fasciitis. So they had, they want to demonstrate whether there's a difference in effectiveness between radial shockwave and placebo for plantar fasciopathy in a randomized controlled trial. So what they found was they had a follow-up at 3 months and at 12 months, and you can see the difference here. There's a 72% decrease in the VAS score with radial shockwave. They still got a decrease with the sham, but it wasn't nearly as great, and even more so at 12 months, where the sham had no change, and the radial shockwave had a significant improvement there. All right, so this study by Romp in 2009. So a previous RCT had shown comparable effectiveness of a standardized eccentric loading training. And so they're basically looking at eccentric loading versus eccentric loading plus shockwave therapy. And the conclusion was that a combination of eccentric loading and shockwave therapy has significantly better clinical outcomes than eccentric loading alone. So that's what we talk about when we'll talk a little bit about when I introduce GDT in a minute. We talk about using rehabilitation in conjunction with the other therapies with high-powered laser and shockwave therapy. And you can see here in the follow-up, 4-month follow-up, there was a greater improvement in the blue, which is the radial shockwave plus the eccentric loading compared to the eccentric loading by itself. Okay, this study, extracorporeal shockwave therapy versus cortisone injection. So again, here the conclusion was both interventions cause improvement in pain and functional ability 2 months after treatment, but shockwave treatment has a better antalgic effect than local corticoids. Patients were more satisfied with radial shockwave treatment, and therefore Swiss dollar class treatment seems to be a safe and alternative for management of chronic plantar fasciitis. So again, we have to remember that cortisone injections hurt a lot, and if you can avoid that and get the same and or better results using shockwave, it just makes sense to go with the shockwave treatment. And also cortisone requires a rest period after the administration, whereas the shock waves, you don't have to do any immobilization. They can walk out of the treatment on the day. And often you have to have multiple cortisone injections, which again can cause plantar fascia ruptures. The more injections you have, the greater the risk. One study showed up to 10 times the risk for plantar fascia rupture when you've had multiple cortisone injections. All right, effectiveness of Shockwave for knee osteoarthritis. This study had 70 patients, one session of Shockwave therapy, 4,000 shocks compared to placebo. And the conclusion was, so the Swiss dollar class. So with the power handle is just the red handle that we have. It's a little higher energy. It penetrates a little bit deeper. So that's why we tend to use it for joints, because we need to get that depth of penetration. It was effective in reducing pain and improving knee function, at least during 3 months after the beginning of treatment, which we can see there in the follow-up. All right, let's go. Danny, are you back with us?
Certainly are. It's going good. Thanks, Adam.
Okay. We going okay? Do we have any questions? Are people getting some questions in?
We do have a question.
Okay.
The question
We'll go through it, but I just want to reiterate to people, we welcome questions. So if you have any questions, please ask them. More than happy to answer, at least try to answer them as best I can.
Perfect. Thanks.
So let's introduce guided Dollar-Class therapy, or GDT. So this is our new therapy that we're promoting. So there's 6 levels that we talk about. So we talk about we want to assess and engage the patient to obviously figure out what their problem or their condition is. We use the high-powered laser in step 2. Step 3, we use the radial shockwave. Step 4, either you can use either the radial shockwave or the focus. You don't necessarily have to use both. And then we talk about this combined therapy that I was discussing, and that those studies showed, is we want to really focus on incorporating proper rehabilitation. And then at the end, we want to do some follow-up. So that's where we talk about like some objective measures and some baseline measures to measure whether we're actually getting improvements, rather than just saying, oh, are you feeling better? We can actually get some objective measures, which I think is great. So we have the 6 steps here. Guided GDT is the new treatment, and we found that it successfully and quickly treats up to 90% of musculoskeletal disorders. Treating patients has never been easier using these devices, and we believe it's a game changer. So here's a little bit about the high-powered laser that we're introducing. It's available now if you want to purchase. So we use, obviously there's specific wavelengths that result in greater therapeutic effects, and most studies show that the 905 nanometers wavelength yields the best results. So we found that with this, you can get within 5 minutes of treatment, you can get acute inflammation to decrease within 5 minutes. It's suitable for patients suffering from acute conditions. So some patients that you can't actually use the shockwave on because it's too tender, that's where this slots in really nicely, because it allows you to treat almost anything, because it's a pain-free treatment. They don't feel anything really, except for some increased heat or warmth in the tissue after it's been held in place for 20, 30, 40 seconds. So that's it's really useful for that. And for some people, again, used in conjunction, when you can desensitize the area, then you can use the shockwave up to within 5 minutes of using the laser. That's when the therapeutic effect kicks in from the laser. So you can start using the shockwave within 5 minutes of administering the laser. So that's pretty cool how we can do that. So here's some indications for the laser. We have rotator cuff, shoulder arthritis, AC joint arthritis, proximal biceps tendinopathy, subacromial bursitis, lateral medial epicondylitis, arthropathy, bursitis. One of our practitioners and instructors, she's been getting really good results with bursitis, she says, over the past few months, which is interesting and cool. We have flexor and extensor tenosynovitis, de Quervain's, Dupuytren's, carpal tunnel, wrist arthritis, cervical, thoracic, and lumbar, disc disease, and intervertebral arthritis of the neck and upper lower back. A few more things: trochanteric bursitis, hamstring enthesopathy, adductor strain, facet arthropathy, lateral compartment arthropathy, Pezanserine bursitis, patella tendinopathy, and you guys can read the rest. So you can see there's quite a few indications, and again, this list is enlarging all the time as we get more and more studies proving its safety and efficacy for different tissues. So some contraindications. There's only a few. Treatment of neoplasms. Obviously, you don't want to treat cancers with it. Again, pregnant women, just because we don't have any studies that prove its safety. And treatment over implanted electrical stimulators such as pacemakers. And here we're just talking about the different aspects, the physics of the laser. So we have the 905 wavelength, which is the most effective wavelength for treating tissues. And we have a peak power of 300 watts, which gives you the depth of penetration, which we show here is up to 120 millimeters. We also have the pulse time here of 100 nanoseconds. So the problem, obviously, when you have a high power is if you leave that on a tissue for too long, it can essentially burn the tissue. So that's why we have a short pulse time so basically it turns on and turns off really quickly. So it's almost like, with X-rays where it turns on and turns off really quick, so you don't get too much exposure. So it allows you to get to those depths without causing any problems, and you still get the therapeutic benefits. So again, 905 wavelength for immediate pain relief, long-term acute inflammation, decrease in tissue regeneration. And then we have the 3 high-intensity diodes that emits the wavelength at high peak power of 300 watts, which is about 15 times more powerful than a lot of the low-level lasers that are used. And again, the reason is because we want to get that penetration depth to get to those deeper tissues. And then we talk about the short pulse duration of 100 nanoseconds. So again, that keeps the treated tissues below the thermal threshold, so you avoid the risk of burning. And so here we go again, same stuff. Clinical studies show that therapeutic effects of laser light on pain reduction, inflammation, characteristic of acute phase of musculoskeletal pathologies are linked to the 905 wavelength. In order to reach the best clinical outcome on deep musculoskeletal disorders, the penetration depth of 905 light needs to be maximized at the high peak power. So that's why we use that. And again, for the safety issues, we do the short pulse duration. All right, we're almost done. Just want to go through the role of all of this GDT and laser and shockwave in the clinics. So basically, we acknowledge that the landscape of allied health is migrating towards a new paradigm, and that is doctors and insurers are demanding more validated, safe, and effective forms of treatment for patients. As an allied health practitioner, it's imperative that we stay current and new with new and emerging treatments such as shockwave and laser, or we risk falling out of favor with healthcare systems, private health funds, and insurance companies. Of greater concern is the risk of becoming antiquated in the health profession. So in order to stay relevant and provide patients with the best possible therapies available, we must learn and adopt these new therapies. It's my strong belief that in the future, insurers and private health funds will only pay practitioners who can objectively show improvements and benefits in their patients. So that's where we're talking about, again, with GDT. We want to do that follow-up to get those objective measures, and then you won't be at risk for these insurers and health funds cutting you off. You'll always be in the loop. Here's the website for the Swiss Dollar Class Academy. We have lots of good information, blogs, videos, and we even have some full text studies on there. So please check that out. And we have a seminar face-to-face, hopefully if the borders stay open, in Brisbane. We'll get some more details out on that, but the date will be Saturday, June 19th. So please look into that. Would be happy to meet you all and teach you some hands-on stuff, which is a little bit more fun than listen to me ramble on all night. When you want to just chill out and have a coffee or sorry, a tea or a nice wine before you go to bed. All right. Thank you, everyone.
Thanks so much, Adam. Brilliant.
Hopefully you're still awake.
I am.
Okay, that's good.
There are two questions. So first question is, you stated that it is better to have higher energy density to get a larger cavitation production.
Yes.
The wider applicator head greatly reduces the energy. So if they tolerate it, would it not be much better to stay with the 15mm applicator? Rather than
it depends on the area. So, and it depends on the how deep the tissue is you want to treat. So if it's say a like a tennis elbow, the tissues are fairly superficial, so you don't actually need the 15mm tip to get the depth, and you can cover a greater area faster. So most people, all you got to do is you turn up the pressure. Most people can't tolerate the maximum pressure on the 15mm. So you don't usually have to worry about that. And even with the 36mm, there's very few people that I'll put it up to 4 bar. It's usually 3, maybe 3.5. So they top out anyway. So you're getting the therapeutic effect anyways. It's just whether you want to get the depth of penetration and how big the area is. So if you're doing someone's like quad, I would definitely use the 36mm to cover the greater area a bit faster. It just takes too long with the 15mm.
Okay, thanks, Adam. Second question. I'm not sure if you can answer this, and Roland may need to respond to this, but the question is, I have also seen that you guys have a concave head for the radial machine, both on the standard head and Power Plus head, theoretically turning it into a focus device. It also increases the energy density and penetration depth. Have you tried this clinically?
I haven't tried that tip. Is that with the new device?
We'll need Roland. If Roland's there, I'm just going to ask him to unmute.
Hello.
Yeah, Roland, there we go. I'll pass that question on to you.
Yeah, sorry, and my apologies. You're gonna just have to repeat that again one more time. Sorry, a bit. I'm having a late dinner and it's noisy.
No problem. So the question is, I've seen that you guys have a concave head for the radial machine, both the standard head and power plus head, theoretically turning it into a focus device. It also increases the energy density and penetration depth. Have you tried this clinically, and when would you use this over the normal 15 millimeter head?
So they're referring to the question is referring to the little focus tip, the 15 mil focus tip.
That's what it seems like.
Yes.
Yeah. And when would that be used?
Correct.
Yeah. Well, if it's a very specific sort of tendinopathy, like a really specific insertional spot, look, the focus is put in there as an option, but most of the best evidence out there is on radial. Radial typically is easier to use because it goes on an outward pressure. It's there just to expand, I guess, your scope of treatment and what you can do with the device. To be honest, I haven't had many clinicians. I know the power handle comes with it traditionally, but the new radial does come with it as well. But we haven't, to be honest, used it too much. It's really just a trial and error thing. If you feel like you need that specific targeted treatment, you could give it a go. But to be honest, my colleague in Germany who's been selling radial and focus, because focus has a higher rebate there, says, look, at the end of the day, it's one device you need, it's radial. The radial is always going to do what the focus does as well. But you can also do more things with radial, ironing, muscle DOMS treatments, and it treats the indicated area and the area around as well. But we just added in as an additional option if you feel you need it. So I hope that answers the question.
Thanks, Roland. Anything to add on that, Adam?
Oh, I actually haven't tried that tip before. I usually I stick to the 15 mil and the 36 mil on mine, and I find I get good results with that. So I haven't played around too much with that. I actually forgot about those tips. So that's good. I might have a play. I might have a play.
Perfect. There's no further questions, but if anyone has any other questions, please don't hesitate to reach out to us and we'll get in touch with Adam. So Adam, thank you so much. And now you can enjoy your dinner.
Okay. Thanks, guys. Have a good night.
Thanks, everyone. Bye.